Now I request Project Director Punjab Health Sector Reforms, Mr. Farasat Iqbal, to come and present that how government has been using mobile governance in health sector.
Bismillahirrahmanirrahim. Honorable Chief Guest, Chief Minister of Punjab, Mr. Farasat Iqbal MNA, Chairman Institutional Reforms Group, members Institutional Reforms Group, Additional Chief Secretary Sahab, and honorable guests, ladies and gentlemen. We know that we all recognize that good governance has been the hallmark of the present government, and though no one can claim that everyone is perfect and ideal today in the government, but no one can deny the fact that this government has been able to make definite and perceptible improvement in governance during past 3-4 years. And how does governance improve? It improves by making piecemeal improvements in public sector management. So in the next 10 to 12 minutes, I'm going to share how we have been able to make some improvements by using information and communication technology in health sector management. Management, we know that lacks timely, authentic information can be neither efficient nor effective. Health department faces serious challenges in performance monitoring. Field monitoring is patchy, irregular, unreliable. Reporting is even more irregular, inauthentic, and has time lag problems. Lacking a system for regular tabulation, consolidation, and analysis of these reports. These are the problems and issues that we faced. Lack of timely and regular flow of authentic information leads to delays and inefficiencies in decision making by management at district and provincial levels, and in turn to suboptimal results in resource availability and service delivery. Now, recognizing these issues, we sought to find solutions. Health Sector Reforms Program sought to strengthen health department's own monitoring system and revamp it by applying information and communication technology. And collaboration was sought from World Bank Proactive Governance Program and International Growth Center grant through a group of researchers at Lahore University of Management Sciences. It was piloted in district Khanewal, which started in November it was actually carried out between November and February 2011, and then it was scaled up to 18 districts since March 2012. We provided, how does this system works? We provided GPS-enabled smartphones to all supervisory officers at district level. The health supervisory officers, these are DDOH, Deputy District Officers Health, District Officers Health, and Executive District Officers Health. These supervisory officers visit health facilities, which is BHUs, RSCs, Tehsil Headquarter Hospitals, District Headquarter Hospitals, according to a predetermined frequency. Schedule has been given that in 1 month, for example, a DDOH has to visit X number of BHUs and RSCs, and similarly for DOHs and EDOHs. And monitoring performers which were part of this intervention were being filled on paper-based, manually paper-based monitoring performer. These are now uploaded in these electronically in these Android phones. And reports are fed into a central backend system. They are uploaded from the facility, and date, time, and location are stamped electronically. Pictures are also uploaded through this system. So chances of fake reporting are almost, they are eliminated. These reports then are automatically processed, and managers' friendly graphs and reports are generated on doctors and staff absenteeism, medicine stockouts, equipment, functionality, availability, and these reports and graphs are available online. And all health managers, from a DDOH sitting, for example, say in District Bahawalnagar, to Director General Health Services, they are able to see the situation on ground, online, in almost, running time, live, they can see this situation. This is some graphic presentations or explanations. Same form, different interface with Google, Open Data Kit. Data and photos are transmitted with GPS time and date stamp, dashboard for live data entry and analysis for managers. This is the digital map that appears on that dashboard. These are the 18 districts enlisted where we have started this intervention. And this is the digital map of each visit. For example, this is one district. Each visit, we couldn't show this here live on internet. That would have been more interesting, but only we are presenting these screenshots. So each visit is here is represented by this mark, and when you click that, the date and time of the visit and other details appear. For example, this one visit is from RSC Kachaku in district Khanewal. Then we click view details. We have this picture of PDO Khanewal sitting with the facility staff. This is another facility. This is BHU. I believe it's district Norwal. This is picture of the training. And these are a few screenshots of this dashboard. For example, this shows officers' compliance report, how much of the facilities have actually been visited during the last month. And this is the picture how these districts are faring in terms of regularity of monitoring visits. These 4 districts, for example, they are below par, and rest are doing according to the percentages shown on the screen. Then there are various indicators which are captured through this system. For example, absenteeism of medical officers. That's one indicator. It shows that, for example, in various districts, what is the compliance level, what percentage of facilities is being visited, and what is the percentage of absenteeism here. This is, again, you can make comparison. For example, provincial level managers can make comparison across districts. District level managers can make comparisons across tehsils, and then they can pinpoint where things are going wrong, where absenteeism, for example, is higher than the provincial average, where medicines stockouts are higher or lower than the provincial averages, and what particular areas need to be focused on. And this information is available live in running time. So corrective measures can be taken very easily, promptly, in a timely fashion, and that time lag issues are resolved. This is, for example, one injection, adrenaline. This stockouts across these tehsils in one district. This is Kasaragod. I'm just showing a few screenshots. Otherwise, it has been available on internet. You could have seen it right there for any indicator, any district, any tehsil, any district. So the same thing. This one, for example, one detailed report. This BHU has been visited at a particular date, and this has been the availability of staff position and all that. And if there is absent staff is absent, that is color coded as red, so that viewer manager can immediately see that this facility had this problem of absenteeism. And here we compare one district's progress since January 2012 to June 2012, and that's the provincial average. So we can see in terms of absenteeism how this particular district is faring as compared to the provincial average. So this visual is very easily, this manager user-friendly system that helps essentially a management empowerment tool. Currently we are doing this in research mode. This is a random controlled trial. 18 control districts where we are making this intervention, and there are 18 treatment districts where we are making this intervention, and there are 18 control districts where no intervention has been made. And now we are collecting data from both these sets of districts, so that we can clearly establish that how this intervention is going to benefit the management and improve service delivery. And when this research phase would complete in October 2012, then we plan to roll it out to the whole of province, all 36 districts. The results are being compared by obtaining data from, as I mentioned earlier, and then we plan to scale up to the whole of province in December, January 2013. This is the districts map, which are control and treatment districts. Preliminary results show that the monitoring activity has improved a lot, considerably, rather very steeply in the treatment districts. Next, this is comparison of the treatment districts with the control districts. Control districts lying flat, whereas the monitoring activity is improved a lot in the treatment districts. Assumption of this model are that improved monitoring and reporting leads to improved information flow both ways, from bottom to top and top to bottom. And then in turn it leads to enhanced accountability at all levels. Well-informed and timely decision making regarding administrative and logistics code is possible. Efficient and economic use of resources possible, and ultimately better service delivery at lower financial and administrative costs. This is a real innovation. We can confidently claim that at least in the health sector, there has been no known precedent internationally, and wherever it has been presented internationally, in Dhaka, in Qatar, in University of California, San Diego, it has been widely appreciated. The World Bank is recognizing the innovativeness and salience of the public sector management reforms, presented this model at various conferences, and many developing countries are also showing interest in the adoption of this model. In cost and maintenance, cost price is not very costly. Our Android phone set is costs around 8 to 10,000 per set, and running cost per month is ranges from rupees 200 to 300 per set. If this research phase is all grant funded, no explanation has been made out of the provincial finances. But if we want to even scale it up to the whole of province, only rupees 14 billion are required to scale it up to the whole province, and annual recurring cost of the system is no more than 2.2 million, 5 lakh service pay Salana Kharcha. Expected outcomes are obviously access to timely, reliable information from facilities at district level, a great empowering tool for health sector managers. It all depends how they actually make use of it. While qualitative change in response level and decision making by the health sector managers at all levels, resulting into improved service delivery at primary and secondary health level facilities, this has great potential for improvement in public sector management. This is not only about health sector management. This is about this is scalable and this is replicable in other public sector areas and sectors. For example, it's already being experimented at Directorate of Staff Development and LHW project within health sector, and then city district government is also showing interest in this model. The possible applications for monitoring of movement of vaccinators, LHWs, data collection from BHUs, including attendance monitoring and all that, all these possibilities are there. And movement monitoring in case of, for example, education sector, they can also adopt this. And next, livestock, agriculture, and very importantly, for example, this is just one idea we've been discussing. For example, photo monitoring of water level gauges of canals by senior managers in irrigation is also possible. Previously, it was done through SMSs. Now, this photo monitoring is possible if this model is adopted. Citizens can see water levels on the internet. I believe irrigation people are better able to judge this, but this is a possibility. Thank you.